I'll put on some gloves so it looks more professional, even though this is obviously a mannequin. And I haven't yet cut into this model, so I'm not sure how that's gonna go, but let's find out. Hey guys, Dr. Gary here. So I wanted to start this rhinoplasty series to show you guys what it's like to do nasal surgery. And I wanted to first start with just the surface anatomy of the nose and give you a sense of not just how things look on the outside, but also what's underneath the skin to give you the appearance that you see on the skin surface. I'll use this little Q-tip to point some things out. When you look at the takeoff point of the nose, you have to consider where is the nose coming off of essentially the top part here, the forehead. There's an area here where at some point it's going to transition from the forehead into the glabella and then your dorsum or the bridge of your nose. So that takeoff point is usually ideally at the upper lash line. So if these were eyelashes, sort of make believe that these are eyelashes, if you look from sort of a side view, that's about where the takeoff point of the nose should be. So we take that into consideration when there are like a hump on the nose or some other situation where we're trying to properly design the bridge of the nose. And then you look further down, and this is not a perfect model, as you can see that the skin is kind of coming off, but imagine that this part is smooth. If someone has a bump on their nose, you have to wonder sort of what's causing that bump. And this is kind of cool. I'm going to lift this off, and you can see this is meant to indicate the cartilages of the nose. So up here is the bone of the nose. So we can remove this skin, or at least like push it out of our way. And this kind of reveals it here, that on the top portion you've got bone, and lower down you've got cartilage. When you have a hump on your nose, it's actually a combination of the bone and the cartilage. It's basically where those two are meeting. Where the bone meets the cartilage, that's where the bump sometimes forms. And then just to kind of give you guys some technical terms, the upper portion of the nose is called upper vault, and that's made up of bone primarily. These are your nasal bones. Then you have the mid-vault of the nose, and that's mostly made up of cartilage. As you can see here, you have the two different, these are called the upper lateral cartilages. And then lower down on the tip of the nose, you've got the lower lateral cartilages, and that's what you see right here. And then running down the middle is the septum. You probably have heard like people talk about deviated septums and that sort of thing. So that's when this central partition is basically crooked or shifted. That gives you an idea of like what is underneath the skin to give you the appearance of what you see on the surface. When you're looking at the tip of the nose, some people, as you know, may have a little bit of a bulbous nose, and other people have a more kind of streamlined, narrow nose. And the reason for that in large part is the curvature of these lower lateral cartilages right here. So if these are very curved and very rounded, they're almost like an arch. If that's what you see on the inside, that's what you're going to see on the outside, okay? The flatter these get, the flatter the appearance on the outside, and again, those become our surgical goals when we're doing different types of rhinoplasty procedures. If you look along the bottom, this is called the columella. That's the portion that's running from the tip of the nose down towards the philtrum. This is good to kind of point out here. I do a lot of lip lift surgeries, as you guys know, and that incision is actually made at the base of the columella, as opposed to for rhinoplasty, if we're doing an open approach rhinoplasty, that incision is made right where essentially you see this little cut in this artificial skin, right at the mid columella. So it's a different location, and that's why it's actually safe to do them together if desired, because you have this skin right in between that actually survives and does quite well because of the great blood supply in this area. I'll also point out here the ala, that those are these side structures here. This portion here does not have any cartilage. It's actually fibrofatty tissue that exists on the sides here. And so sometimes people ask me to do alarplasty or alar base reduction surgery for them, and we're removing then a portion of this ala on the side, and sometimes the nasal sill, which are right here. Make sure you watch until the end of the video, because I'm going to reveal what are the different pitfalls, what are the things that can go wrong during a rhinoplasty, rhinoplasty, it's very important to know not just what you want to achieve with a rhinoplasty, but all the things that could potentially go wrong and why they happen. Let's talk about the bridge, otherwise called the dorsum of the nose. That's going to be this area here. And a common complaint that I hear is that, you know, people don't like the hump that's on their nose and they want to reduce it. How do we do that surgically? The two general approaches are through a closed type of rhinoplasty approach, where the incisions are all made internally. That's on the inside of the nose, so there's no outer cut. The incisions are all internal. You can do that to then use that approach to reach those cartilage and that bone of the dorsum of the nose to basically adjust things up there. The other method is the open approach, where a small incision is made here. It heals generally very well, and so it's usually kind of a complete non-issue with an open approach if it's done right. And this incision is used along with some incisions on the inside of the nose, and basically the nose is sort of what we call degloved, where you bring the skin and the soft tissue up until you see the cartilages. First you see the lower lateral cartilages, then you see the upper lateral cartilages, and then you get, if you go further up, you'll get to the bone, the nasal bone, as we previously talked about. So again, the hump that people have is always a combination of the bone being a bit too prominent and sort of sticking up, as well as the cartilage here. The cartilage here that's sticking up is a combination of the septal cartilage, and that's what lives and rides along the middle, as well as these upper lateral cartilages. They both can sit proud and meet up with the bone, and then you get this hump. So when you're reducing the hump, you have to reduce the cartilage and you have to reduce the bone. Okay, so I'm going to actually try to get into this model. I'll put on some gloves so it looks more professional, even though this is obviously a mannequin. And I haven't yet cut into this model, so I'm not sure how that's going to go, but let's find out. So we have, again, the lower lateral cartilages, and there should be a way here to kind of divide them. Maybe not so easy. Don't want to hurt myself here, but let's see. If it's not working, we'll just kind of chat about it instead of showing it. But it's always kind of nice to show. So again, I'm trying to divide these lower lateral cartilages just to kind of show you guys what I'm talking about when I say the septum, because it's kind of confusing because you've got septum on the inside of the nose, right? But it's really coming from up here. It's all one continuous piece. So I'm just trying to separate the septum. Oh, here it comes. The septum from the lower lateral cartilages. And now I'm on the right side of the nose, and I'm going up beyond the lower lateral cartilage, and I'm going up into this upper part where you have upper lateral cartilage. And I'm just kind of separating it out so you guys can get a better sense of what's going on the inside. You know, normally it's a little less barbaric in surgery, but also normally you have a lot of more bleeding that's happening. So now I've kind of separated that out. I'm going to do the same thing on this left side so you guys can get an appreciation for the two separate sides, and hopefully I can do this without messing up this little mannequin. And I'm just doing this to kind of show you guys our general approach when we do mainly an open approach, and there's a lot of different things that we can do once we get the nose opened, but this will give you a bit of a better understanding here. Okay, so great, so that kind of worked here. So now I'm separating the upper lat on the left side, upper lateral cartilage, from the septum. We are making a little bit of progress here. This material is not that easy to cut. Okay, so now the left side is opened up. Left side's opened up, the right side's opened up, and then you've got the septum in the middle, right? So this is kind of what you have to do when you're addressing the dorsum of the nose to remove the hump. Now, if you're doing a closed approach, you kind of are doing this a little bit more blind. It's all done through the nose, so you're not really seeing it in the same way. So it takes a lot of experience to be able to do it closed. For the bridge, I think It's appropriate to do closed for tip work, especially advanced tip work. It's almost impossible to do a great job closed, so most rhinoplasty surgeons around the world are doing open approach for the tip. For the bridge, some people, you know, can get away with closed and still do a nice job. So that is that. So now, as we get to this cartilage, so now you have the septum right here in the middle. You've got the lower lateral cartilages out here, and then the upper lateral cartilages are coming in over here. So if we want to bring down this bridge and sort of reduce that hump, what we do is we start taking away some of this cartilage. So I'm going to just show you guys how, you know, I'm going to trim just a little bit off here, just so you get a sense. There's a little bit of a hump actually in this model. Again, it doesn't cut very easily in this model, but normally it's much smoother, and usually I would take like a curved scissor and I would just go right over the top. It has a little bit more of a curvature than this type of scissor, and we would just kind of cut and reduce down that cartilage first before I get to the bone, okay? So here we go. Sorry if I'm blocking the view. Okay, so again, I'm not going to do a whole lot. This is just kind of to give you guys a sense, right? So that's it. So now imagine this was your septal cartilage at the dorsum at the top, right? We've removed a sliver, so that's going to bring this down. And next, we need to go into the bony part and start shaving it down. So imagine I have a rasp here. We're going to flash one on the screen, but I don't have it right here on my table. So we're going to imagine that this Q-tip is a rasp, and then you find the bone underneath the skin. You get up in there like that with your rasp, and you probably have seen videos where we're doing these types of movements during rhinoplasty, and what that's doing is it's bringing down that bony level. So now you've removed some of that cartilage and you remove some of that bone, so you have a flatter bridge and one that's more in line. And there's a lot of nuances, right? Sometimes you don't take the bone down quite as much as you want. Sometimes you still leave a little bit too much cartilage in this area. After, when the person heals up, there's still fullness there. It just doesn't have a clean transition from the bridge to the tip. And that sometimes is because this cartilage hasn't been removed, not enough of it has been removed. So there's lots of different things that, you know, you have to kind of think about while you're doing the procedure. The other point to make here is when you're taking down that hump, and you flatten this out, right? So now you have something called an open roof. And if you just leave that, we call it an open roof deformity. So oftentimes when we're reducing a hump, we then need to reestablish, so what I tell people, reestablish the roof. So what I tell people, it's almost like a house where you've cut off the top of the roof and now you have this opening. You need to reestablish that roof. The way to do that is doing what's called osteotomies, or little bony cuts. So that's like breaking the bone. That's what that refers to. So usually we'll go in with a little chisel and a mallet, and I'll position it onto the nasal bone up here, okay? And we'll use a little mallet and we'll do what's called medial osteotomies on both sides, and those are just cuts right here in the bone. And then from the inside of the nose, I'll put the chisel right here. We'll tap, 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 and you can imagine imagine on the inside, but if you're looking at it from the outside, this is all bone out here. This is cartilage, but this is bone. So you're making little cuts in the bone, and after you do that, you can take the nose and essentially you push it in. You push it in, and now you've reestablished your dorsum. So it's not flat and wide anymore, it's more narrowed and more reestablished. So that's the way that you kind of get it back to looking normal after you've reduced the hump. So that's just kind of a basic idea of hump reduction and kind of why you do it, how you do it, and those are the general steps that we take for that type of procedure. So the septum of the nose is very important. It runs right smack in the middle of the two sides. It separates the left from the right. And a lot of times people go to the doctor and they're told they have a deviated septum. Well, I hate to break this to you guys, but 95% of people have a deviated septum. Most of the time, it doesn't matter. There's no consequence of it, okay? So just having a deviated septum is not enough to warrant surgery. You want to have a deviated septum and a functional problem like difficulty breathing to justify doing a surgery for functional reasons. But then if we're talking about cosmetic reasons, sometimes when you have a septum that's kind of crooked, especially in the front part of the septum is this portion here. This is what we call the caudal aspect of the septum, as opposed to the other parts which are further up and back, right? So this front piece here, this is the septum here, and there's the caudal septum. So in some patients, some people, it's just kind of crooked. And when this is crooked, if we were to put the skin back on, and let me see if I can move this for you guys so you can maybe see. If you put the skin back on and now you have a septum that's crooked, do you see what it's doing? It's moving the entire tip of the nose to the side. So when that happens, you need to do surgery if you want to try to create a straighter nose. So the septum is important for cosmetic purposes as well as for functional purposes, because if that septum is over to this side, well, guess what? You're not going to breathe too well from the right side of your nose. It's equally important for both, and so having a nice straight septum is just the most important thing surgically that you can do for someone. And sometimes it can be very hard to achieve such a straight septum because cartilage, all cartilage has memory. So even if you try to get it nice and straight with sutures and with moving it around, over time there's still a chance that it might shift a little bit, and that's just the nature of cartilage. It has some built-in memory, so you usually have to do a lot to it so that it doesn't resort back to the way that it used to be. I want to point out too, when we're doing surgery, there's a risk of what's called a septal perforation, and that's actually a communication between the left and right side of the nose, because sometimes you can get a little hole going from one side to the other. And the reason that happens is because when you're raising, you've got inner lining, inner skin of the nose. You've got to raise it off of the septum on both sides. And that really is, I would say, the most challenging part of rhinoplasty surgery, because if you don't get that tissue removed off of the cartilage itself and have nice bare cartilage, you run the risk of having a hole on one side, and then if you have a hole on one side and a hole equally on the other side, then over time, if you, what we call perforated your inner skin, you can get a communication, and those are hard to fix, and they can be really kind of a troubling issue for people. So it's better to avoid it, and that's done through proper technique. There's always, of course, a risk anytime you do rhinoplasty for that kind of complication, but it almost always can be avoided. That's what I'll say about raising the skin off of the cartilage. And then in order to straighten the cartilage, right, like what can you do to straighten it? Well, sometimes you can just basically remove an area that's causing it to be crooked. And sometimes that area is along the base of the nose where we have what's called the maxillary crest, or that's the bone of the upper jaw. And sometimes that crookedness is actually from a bone that's much further back. The septal cartilage, when you keep going back along the nose, you run into what's called the ethmoid bone. The ethmoid bone can be crooked. And when you have a crooked ethmoid bone, then that basically causes the cartilage to also deviate. And so addressing all those areas of deviation can straighten out the cartilage in most cases. Sometimes the cartilage itself is crooked, and you have to literally chop off a piece of this caudal septum, and then on the back table you have to like remold it into something straighter. And sometimes I use a material called PDS, a PDS plate. We'll flash what that looks like on the screen, and I attach a straighter piece of cartilage onto the PDS plate, and I put it right back into the nose, and then I have to secure it. You have to secure it back into the nose, or else it's not going to stay straight. And we usually secure it to this portion up here where you have the upper lateral cartilages, as well as the nasal spine, and that lives right down here on the other side, basically the deep aspect of your columella. You have a nasal spine, and that usually is right smack in the middle. So the piece that you put back in, you attach right in those areas. And sometimes even if you're not doing that kind of more advanced work where you're removing a piece of the caudal caudal septum. That's called extracorporeal reconstruction. That's kind of advanced. Even if you're working with the cartilage internally, you can hook it up to this nasal spine, and that will get it into a straighter position. So now let's say you have a straighter septum. That's a huge accomplishment for a rhinoplasty already. And then what do you do next? Well, there are a couple of things you can do, because next you're going to have to work with the tip of the nose, right? And those cartilages are what we talked about here, the lower lateral cartilages. And there are a couple of things you can do before you start working on those cartilages. And I'll tell you guys what those are now. One option is to do something, and this is called grafting. This is basically taking cartilage, and that can come from further back in the septum. Sometimes we harvest cartilage further back in the septum if there's cartilage there, or if it's a revision type of case, we might have to take cartilage from the ear, or we can take cartilage from the rib, or sometimes cadaveric cartilage from a cadaver can be used. And you take those that cartilage and you basically sculpt little pieces of cartilage called grafts, and then you put those back into the nose. So this is something called a septal extension graft, right? That's what I've kind of created here. And you can put that into the nose right next to the existing septal cartilage, and you can basically put a stitch through. And so the question is, well, why would you do this? Well, if you want to then reposition your lateral cartilages, these side cartilages, to give your nose more projection or give it more rotation or derotation, you have to basically hook it up to something in order to give it stability. And that's when you would consider doing this type of graft work. So if you're trying to control how rotated or projected someone's nose is, one good way to do that is through what's called the septal extension graft. So it hooks up to your caudal septum with a stitch. So I'm going to attempt this here. We'll see if this actually works, but just so you guys can get a sense, we're going to take a suture that we don't normally use in rhinoplasty, but just kind of what I have laying around. And we're going to see if we can make this work. So I'm going to move the left lateral cartilage out of the way, and I'm going to grasp the septal cartilage, and I'm going to grasp my graft, and I'm going to go through. I'm going to go through, and you can see it right here. I'll move this out of the way. You can see it coming through right there, right there. So right there, here it is on this side. So now we're going to go back through, and this is a long suture. We're going to go back through the other way, and here we go. So we're going to grasp. So everything is being held nicely together, and I'll be looking on this side. And this is actually how I do it in surgery. The general steps are the same. And this is, again, putting in a septal extension graft to give myself more control over the tip of the nose and just more stability to the nose. The other reason to do this is when people smile, sometimes the tip will drift down. You probably have seen that. And this is a good way to combat that, because now you've given the nose more stability and strength. And in doing so, when you smile, the tip shouldn't go down. The disadvantage of using this technique is that you create more rigidity in your nose. So when you touch the tip of the nose, it's a little bit more rigid, but you get a lot more stability overall for, you know, for a lifetime. So I think it's worth the trade-off. So here I am just adding in this suture to connect this septal extension graft to the cartilage that you're seeing here, the septal cartilage, okay? So I'm going to do one more here, and then we're going to just cut for ourselves. Right there. Cut this one off. Good. And so now it's in place, okay? So again, we can now do things to it. We can work on attaching these lateral cartilages to it in different directions. We can bring this up to rotate and project the nose. We can bring it down. Like, let's say someone had surgery for rhinoplasty and they ended up with like a overly rotated, almost like a pig's nose where it's overly rotated. Well, how do we correct that? We put in a graft like this and we bring the tip cartilages down. And that is how we de-rotate the nose. Same thing with projection. You can de-project in this way. You can project the nose in this way. So that's a powerful technique. The other method that I wanted to show you guys to attach the cartilages, which is what some people do, is this other type of grafting, which is called a columellar strut graft. And that's a kind of a smaller piece of cartilage, and that is more free floating, meaning it's not attached to your septum, right? Here we are attached to the actual septum. When people put in columellar strut grafts, they're not attached to the septum. And so it's just a different approach, and usually it's placed somewhere down here. There's not much room because I had the septal extension graft. But this is another way to do it. You basically put a free-floating piece of cartilage, and then you can again take your lower lateral cartilages and hook it up to that, and again control the tilt of the nose. The problem with that technique, in my opinion, is that over time there is a drift down to the nose. So you're not really solidifying the nose in position for a long, long time to come. You know, you run the risk of eventually having some droopiness to the tip. So that's the downside of this technique, but you get a little bit of a softer tip. It's not as firm because it's not connected up to your actual septum. It's more like this, free floating. So that's a columellar strut graft. It's another technique that's used for positioning the tip of the nose and for adding some degree of stability. And before getting to the conversation about the tip, I also wanted to show you guys these other grafts, which are called spreader grafts. And that's done to reestablish the middle vault of the nose, and those are placed, let me show you guys right there. Those are placed essentially coming down between the cartilage of the septum and the upper lateral cartilages. So something like this. I don't have enough instruments and hands to show you, but you can sort of see here where a spreader graft would go between the upper lateral cartilage and the septum, the dorsal septum. And doing this can also help close that open roof deformity that we talked about before. That's another strategy for it. It can give you a little bit more width in this mid-vault section, and it can also potentially be used as a special extension spreader graft to further solidify your septal extension graft. So you can hook this graft up to this graft from both sides, and now you have a really rock solid midline structure. Okay, so that's that graft, and that also gets sutured in, but you know, you guys get how that works. I'm not going to show you again for that part of it. And then we're gonna get to the tip next. So now we've worked on the bridge of the nose, and we've worked on the septum, and now finally we're at the tip of the nose, and that's really where it gets really challenging when it comes to rhinoplasty, and just from the surgeon's perspective, and also, you know, where patients really want to see a lot of change. And the reason why it's so difficult is because of these lateral cartilages, lower lateral cartilages, and they have usually sort of a roundedness to them. And the reason why they're that rounded in many people is because they're there for stability. If you look at like a building that has like a dome type of ceiling to it, those are very strong buildings, and that's kind of how things were built back in the day for stability. It's just geometrically a very kind of strong way to build, and that's why many of us have this roundedness. It gives us strength, but when you look on the surface, you have this kind of bulge, right? And that's giving you sort of a wider, more bulbous tip. So people want it more narrowed, they want it more defined. So the question is, how do we do that? There are different techniques for that. The way that it is most commonly done by, I would say, 90+% of surgeons in many instances, is to do what's called a cephalic trim. A cephalic trim identifies an area of lateral, this is the lateral crus of the lower lateral cartilages, intermediate crus, these are the domes, and then this is the medial crura of the same piece of cartilage, and we'll flash some anatomy on the screen so you guys can review. But what we're trying to do is look at this lateral crus and try to remove some of that bulbosity or some of that roundedness. So we have to preserve at least, generally it's considered 6 millimeters, if you can do 7 or 8 millimeters, and that's measured sort of this way. And we want to preserve that amount, and the cephalic trim basically cuts off some of the cartilage up above beyond that point of preservation. So what I'm Xing out here is the part that gets removed. And this material is a little hard to cut, as we've discovered, so I'm not going to go through that ordeal right now, but you can imagine when you cut this out, you now have a little bit more of a flimsy piece that you can then try to flatten. There are different ways of flattening this piece. If you don't flatten the piece, you still get that roundedness, right? So now that you've removed this upper portion and are moving towards trying to create a flatter piece, you can create flattening by stretching this lateral cruise against your septal extension graft, for example, or even stretching it towards the other side, but ideally through a septal extension graft. That's going to give you what's called tensioning. So you're kind of like, if you have like a tent pole, you're pulling that lateral cruise towards your tent pole, creating that tensioning and flattening out this lateral aspect. That's one way to do it. You have to make sure that your forces on either side are pretty equal, or else later on when you're healing you can deviate towards one side if one side is tensioned too strong compared to the other side. That's one way to do it. Another way is to put a graft underneath here. So you have to carve out, dissect, and remove and separate what's called vestibular skin. Here you don't see it. This is just like supposed to be cartilage, but in reality we all have some skin here. So you've got to separate those two planes. So once that is separated, you can take a graft such as this one. I'm going to show you with the smaller graft first, and you can stitch it to the undersurface of this cartilage over here, and by doing that you can essentially splint this lateral cruce and flatten it against that material, right? Usually this would be cartilage. So I will attempt to show you guys that type of splinting just so you can see what that sort of looks like. Again, this is not strong enough in this model to give you good flattening, and it's a little bit difficult to work with, but I will try to use my scissor to stabilize, which is not working very well. And this is kind of how we futz around with it during surgery, more or less. I mean, usually I have an assistant, right? But still, it's not easy. It's always a little bit of a challenge. And this is what makes rhinoplasty both fun and difficult. So here we go. So we're going in from the outside. We're going inwards. I'm trying to hook this piece that's internal now. I'm going to hook it that way. Stretch this out. I'm going to reposition my needle and then go back through here. Back through here. Okay. So that is a lateral crural strut graft. Right there. Okay. So the lateral crural strut grafts can be used to flatten the lateral crura, which again can help reduce that bulbosity or that roundedness that you see. Now, what if that doesn't work, right? You've done this, nothing's working, what else can you do? So now we're talking about more advanced techniques where you can actually go and release this lateral cruce all the way from its attachments. It's attaching all the way down here at the sesamoid cartilages, which are these little tiny little baby cartilages all the way down here. So we're gonna just attempt to do that with our model and just try to detach all the way. I mean, this is advanced stuff here, but it can be done. It's not done in every case, but for my revision rhinoplasties, I'm doing this more and more. And sometimes even for primaries, you know? So you can do this. You can literally go in there. You can even cut this whole thing off. You can remove it as long as you obviously reconnect it and resupport it. But you can then remove it and you can do what you need to do with it. So sometimes we'll do this and then we'll cut out the end portion because maybe that's just getting in our way. Okay, maybe that's just what's creating some of the roundedness. And we can attach an even longer graft, a nice, strong, longer graft, longer lateral crural strut graft down in here, and then we put it back into the nose. And again, it's going to be hard to show you with this model, but this then goes into the nose, and you're really then controlling the positioning of this lateral cruce. And what I want to show you guys next is this. So if you look from the outside, you see this little bump, right? And that's what a lot of people don't like. Now, if we were to put in all these grafts and find a way to flatten the cartilage, you would get something more like this, where now that bump goes away. So without it, you have a bump, right? Flattening that piece gets rid of the bump, and that's what a lot of people like. The trick is to not reduce the strength of your cartilage. You don't want to reduce the strength of the whole lateral sidewall of the nose. You want to preserve strength, because that's what's going to be with you for a long time, and you want to breathe well, but you also want it to look more streamlined. Those are the different strategies that you can take. You need sufficient cartilage to do these different things, but that's the concept. And then at the end of the procedure, we'll put the domes of lower lateral cartilages together, and we'll just kind of connect everything together. And then, of course, the final step is we have to suture everything closed, and this is a very crude representation of the suturing, but this is kind of generally how we do it. We take the lower skin, we take the upper skin, and we connect the two, and we do a series of sutures down along the base here until it's nice and closed. And this is all very loose, so it might be a little bit difficult to suture, but you guys will get a sense of it. I'll try to be as controlled as we can be here. All right, so here we go, it's coming together. So now the tip of the nose is back down, and we are closing, and you'll have little sutures here, and then that gets removed at a week, right? Unless they're dissolvable, in which case there's nothing to remove. So let's talk about some of the pitfalls that can occur and different complications or things that occur. So of course there is the potential for the nose to deviate, right? If it's not immediately after surgery, it could be months, sometimes years later, because if you're doing all this suturing and putting in all these grafts, you don't know exactly how it's going to react over time. So there could be some play and some deviation that occurs, especially if you originally started deviated. It can kind of return back a little bit to how it used to be. Some of these sutures might kind of come undone a little bit, and even though you flattened out your lateral cruce, in the recovery process, sometimes it can still kind of stand up a little bit too tall, and you can still get a little bit of bulbosity on the outside. Sometimes when you break the bones for the upper part of the nose, you just basically don't break them in the exact right places, and you can get little things called rocker deformities where the bones aren't completely aligned. If you don't break the bones enough, then you can continue to have your open roof deformity. There's something called an inverted V deformity, where you basically lose support in the midvolt, and that's where these spreader grafts come in, right, to try to support the midvolt so that you don't get that kind of collapse and what's called the inverted V deformity. There are other things, bleeding, infection, there's other things that could occur from a rhinoplasty, but generally all those things are pretty uncommon. There's bleeding, but it usually dries up after 48 hours. Septal perforation we talked about. You can continue to have a deviated septum. Sometimes again that septum can deviate back from where you originally had placed it. There are skin changes, risks to the skin, because especially if you're doing an open approach, right, and you're pulling the skin up and then you're putting the skin down, if you in the process of putting the skin up went through a lot of these blood vessels that live on the other side of the skin, you can injure that skin and it can become a lot less healthy. And there have even been times when the skin can turn black and you can lose a lot of that skin. That's usually after many revisions, or if the procedure is just really not done correctly. Also the incision here, if it's not placed correctly, it can be aesthetically displeasing. Lots of potentials for pitfalls, and that's why you want to find someone who knows what they're doing, done a lot of these, who continues to do a lot of these types of surgeries, rhinoplasty and revision rhinoplasty. Once you get used to revision complex rhinoplasty, doing a more primary type of rhinoplasty becomes a lot more straightforward. Hopefully you guys found this useful. Leave some comments. Please like the video if you enjoyed it. If there's anything else you want to see, make sure to let us know. Make sure to subscribe and check the notifications button so you can know when we have a new video. I always talk to my patients about the specifics of all the different grafts that we're planning on using. The more knowledge my patients have, the better equipped they are at making different decisions about, you know, how they want certain things done. And I think it's empowering for patients to really know this stuff and not see it as like a black box. And you should feel free to ask your surgeon, well, are you going to use this type of graft? Where are you going to get the cartilage from? These are all valid things. Like, your surgeon should have already thought through this. And if they haven't, then you might consider going to someone else. You got to have a plan in mind. You have to be able to pivot intraoperatively. That's what makes surgery challenging and exciting. It could be even more comprehensive talk, but try to cover all the essentials and give you some of the specifics, but also kind of keep it as an overview of the topic. Once again, Dr. Gary here, signing out. See ya.